Memorial Day weekend. And so we are starting off this week with a really important topic, and that is food insecurity among older adults. And as I mentioned, we have two speakers who are joining us today and who will be presenting on our topic. And our first presenter is Dr. Akobundu, who is a registered dietitian and serves as the Senior Director of Nutrition Strategy, where she leads the development and implementation of the Association's strategy on nutrition and malnutrition. This work includes the design and execution of projects that demonstrate and strengthen the evidence base for senior nutrition programs. In addition, she works collaboratively at the national level to build knowledge and skills among nutrition and aging professionals in the healthcare integration, business acumen development, program evaluation, and food service management arenas. She also serves as the director of the National Resource Center on Nutrition and Aging, awarded to Meals on Wheels America by the Administration for Community Living of the U.S. Department of Health and Human Services. Dr. Akobundu holds a master's in nutrition with a concentration in public health from the University of Massachusetts Amherst and a PhD in nutrition from the University of Maryland, College Park. We are also joined today by Dr. Heather Hartline-Grafton, who is a Senior Nutrition Policy and Research Analyst at the Food Research and Action Center, or FRAC. Her work primarily focuses on obesity, dietary quality, and health among low-income and food-insecure children and families, with emphasis on how the federal nutrition programs improve health, nutrition, and well-being. She also is actively involved in FRAC's work on addressing food insecurity in healthcare settings. Dr. Hartline-Grafton, who joined FRAC in January 2009, has a rich background in nutrition policy research, obesity prevention, and healthy eating strategies, including her prior work at the American Cancer Society Mathematical Policy Research and Tulane University. She is a registered dietitian and holds honors bachelor's degrees in nutritional sciences and dietetics from the University of Maryland, an MPH nutrition from the University of North Carolina, and a doctorate in public health in community health sciences from Tulane University. We are very happy and pleased to have our speakers today talk to you about food insecurity among older adults. And I will turn it over to, I believe Dr. Akobundu will be starting our webinar today. Thank you. Dr. Akobundu, are you possibly on mute?
Thank you so much. I was on mute.
Okay.
Apologize. I'll start again. Hello, everyone, and welcome. Thank you for the opportunity to speak with you on the webinar today and share with you some information about the nutrition needs of older adults. I'm pleased to be joined by my colleague, Heather, and who will be talking more about food insecurity and opportunities for clinical staff to engage in the good work of identifying food insecurity for the betterment of all patients, particularly for older adults. But let's kick things off this afternoon talking about nutrition needs in seniors and why this matters. So I'll get started today by setting the stage for our conversation. If you would be so kind, the next slide, please. And the next one, thanks. And the next slide, please. is an overview of my talk today. It will take about 30 minutes to tell you a little bit about why a focus on older adult nutrition matters, share with you some select community-based nutrition programs that serve this population, and close today with a call to action as to what you can do in your areas of professional work and setting to advance the cause of ensuring that older adults have access to the nutrition services that they need. So on this next slide, I will want to learn a little bit about you. If you would be so kind, I think there's an opportunity today to launch a poll. I'm very interested, if so, to find out about your knowledge about aging services available in the community. If the poll can be launched, great. Otherwise, I'm happy to hear from folks in the chat box about where they feel they fall on this continuum of either being very knowledgeable, somewhat knowledgeable, or not knowledgeable at all with regard to aging services in the community. I look forward to hearing your answers to this question by just typing into the chat box with your responses. I'm not seeing responses on my end, but I'm happy to move forward into the next slide if that's a preference. Excellent. So let's get started a little bit, focusing on why older adults matter and their nutrition needs in particular. On this next slide, I start the conversation by looking at our nation's seniors. We do know that the population of the United States is aging. At present, 1 in 5 older adults is 60 and older, and we know this continues to rise with every passing day. We know that 12,000 or so pass 60 every day, and due to advances in medical and social health care, we are seeing high average life expectancies. 79 years is the number of years that an average American can expect to live. And with that comes great opportunity, but also great challenge with regards to ensuring that this growing number of older adults have access to the health and nutrition services that they need. This is particularly important as we know this population is set to double, more than double, in the coming years. We see this population growing to about over 100 million. Just by 2060, a few short years away. On this next slide, we are able to share a little bit more information and dig into this challenge a little bit more. Next slide, please. We see that this demographic change is particularly important as the number of older adults will surpass the number of children in a few short years. So it's so important that we pay attention to the nutrition needs and the social health needs of this population. We know that about 6.9 seniors live in poverty at present. This means that they contend with a weekly income of about $228 or so, leaving very little for housing, utility costs, and medical expenses. And, of course, food. As a result, 1 in 6 seniors, as I mentioned, struggle with hunger in the country. We know that access to healthy food can be a challenge as we age, leaving older adults at risk of poor nutrition and associated health conditions. There are several reasons why access to nutrition is challenging as we get older. These relate to age-related, biological, economic, social, and functional challenges that limit our ability to access, acquire, prepare, and consume the foods that we need. We know that these challenges face a number of those in the community, leaving about 1 in 4 seniors particularly challenged because they live alone and have less ability to access the resources they need. This places significant strain on our health care system in this country, threatening our economy as well. So it's so important that we're able to provide consistent access to high-quality nutrition services to support all older adults in the community and their ability to remain independent in their homes of choice. We know that particularly food insecurity, that is that uneasy access to the kinds of foods that folks need, can also confer a 14-year disadvantage between those seniors who have ready access to meals and those who don't. Next slide, please. Next slide, please. Next slide, please. Great, thank you so much. Even with this information about the nutrition services and the needs that our seniors have, we know that so many don't yet receive these services. A recent federal report indicates that 3 out of 4 seniors don't currently receive this, and this is particularly of concern for those who are in need. In fact, 83% of low-income, food-insecure seniors are not receiving home-delivered meals in particular that they might need. And so this is a challenge. Next slide, please. Next slide. Thanks. Perhaps it's the network on my end that's having difficulty. Wonderful. Thank you so much. Wanting to draw your attention to the fact that hunger is a challenge in this country, as that sometimes is difficult to wrap one's mind around. I'm remembering a recent Washington Post article that was posted in the summertime a couple of years ago with this headline: "Hunger receded after the recession, but not for older adults, new figures show." And this is important to realize that it is a challenge, yes, of many older adults, often who are hidden from view from the general populace, but every so often does make the news. And so it's important for us to understand the implications of this work, the ramifications for the individuals that we serve, both in clinical and community-based settings, and how we can leverage our resources collectively to make a difference. Next slide, please. So let's talk a little bit about getting older and what impact that might have on our health in particular. If we look at the interaction between nutrition status and this process of getting older, aging, we see that there are 4 main areas of particular interest, or areas in which changes do occur. These are in our medical, physical, cognitive, and environmental status. From this diagram, you can see quite clearly that these factors all interact with each other. For instance, in the medical health arena, we see that having a chronic illness, using medication, may result, and often does, in sensory changes. These are changes in our ability to taste, smell, and contend with the different textures of food, and our oral health, in fact. It is the combination of these changes that make it hard for us to enjoy the foods that we once loved in our younger years. Looking at section number 2, our physical functional status changes, there may be changes in our physical limitations, our ability to balance, stand at a counter, prepare foods at a stove, our endurance, our ability to go to the grocery store, walk through the aisles, access the food that we need. These also impact most certainly the nutrition status that we have. In this third area of cognition, there might be changes to mental status due to a stroke, due to other health impacts that might happen. Changes in our social circumstances, losses of loved ones, for instance, that might impact our food intake. It could be over the course of our life. We have acquired health and nutrition-related beliefs, and all of us subject to advertising that really do impact how we perceive what's available, what we perceive in terms of foods that we need to eat. Lastly, environmental changes in our living situation, in our lifestyle, transportation systems available in our neighborhoods, all also combine to impact our ability to access, acquire, and prepare and consume foods as we get older. So it is this bi-directional interaction between nutrition status and aging that's important to bear in mind. impacts on our nutrition are not necessarily just economic, as often they're perceived to be, but as we age, are a consequence of a myriad of these factors. Some of these are noted here. Next slide, please. So if we look along the continuum of care, for instance, we can examine areas in which older adults are vulnerable as they pass up through these different segments. In the community, I just outlined some of the risk factors for poor nutrition, but let's consider in the case where an older adult is hospitalized and is admitted to an acute care setting for care. We see that often upon admission, up to 50–60% of older adults are malnourished at admission. Often, due to a focus on the acute care needs of the older adult, there is either an absence of nutrition screening or a delay in getting nutrition-related screening results to healthcare professionals who can address this issue. During hospitalization, we know that this is a challenging setting for older adults. Their diets often are impacted due to the hospital stay in question. There may be differences in the diet due to the treatment that they're undergoing. There may be a delay in receiving the nutritional consultation they may need. Often during meal times, this might be a lonely time for an older adult, having to contend with that tray all alone and consequently may eat less than they usually do during a hospital stay. Finally, during transitions of care between one setting of care, say an acute care hospital, and another, their home in the community or a skilled nursing facility, there might be an omission of that nutritional care plan that does not follow them completely from one setting of care to the next. There may be limited support in this new setting of care as they transition from the acute care setting to meet these nutritional needs, say in the home-based setting or in the skilled nursing facility that they transition to. So we can see at any point there are different threats to nutritional status that might follow a senior depending on where they fall along this continuum of care. Next slide, please. So when we look at it in just in its totality, we see that there's several risk factors for nutrition, many of which we identified, but some additional ones to pay attention to, particularly for older adults. These factors say social isolation, depression, repeated hospitalization, financial constraints, in addition to feelings about one's inability to access food can also be a challenge. So it's so important to know that threats to nutrition are multifactorial and need a multifactorial response. Next slide, please. Next slide, please. So for this presentation, in my next slide, I am transitioning to looking at nutrition programs in the community. And for this presentation, I just have highlighted a selection of slides, a selection of programs that address the needs of seniors in the community, and we'll be talking to you a little bit about these. I'm not sure, I'm not seeing the next slide, but perhaps it's visible, so I'm happy to continue with the presentation. What I am starting out with is a general overview of these community-based nutrition programs. These particular slides, slide number 16, highlights the different programs that are available through the U.S. Department of Agriculture as well as the U.S. Department of Health and Human Services. Thank you so much. These programs are listed here. I will not talk too much about the SNAP program, as I know my colleague Heather will in her presentation, but I'll also talk more about the Community Supplemental Food Program, the Emergency Food Assistance Program, the Senior Farmers Market Program, in addition to community-based programs for older adults. You can see by the dates here, just to give you a simple timeline of when these programs were instituted in this country, dating as far back as to 1960 and more recently in the early 2000s. Next slide, please. Briefly, in the next slide, I'll be talking about the Supplemental Nutrition Assistance Program and providing just a brief overview of this initiative. The Supplemental Nutrition Assistance Program, or SNAP, is designed to help folks of low income buy the foods they need to support their health. Most programs, as this is a Supplemental Nutrition Assistance Program, must spend some of their own money along with the benefits they do receive to acquire the foods they need. This program is a state-run program. However, we encourage that SNAP applicants may have resources but have to qualify for the program. On the slide, I list different qualification criteria for you to see. For most households applying or qualifying for the SNAP program, we see that it's about a monthly income of about $2,000. Most states have exemptions to ensure that folks are able to qualify for the needed services. For instance, one's home does not qualify as a resource that is evaluated for qualification. On the next slide that follows that, I talk a little bit about another program, the Commodity Supplemental Food Program. But I will take a minute here and pause just to make sure that the slides are in fact advancing. I'm wondering if Heather or Sarah can advise. From my end, I can't see the slide advance past the programs for older adults slide 16.
Uche, this is Heather. I have you on slide 18 with the CSFP.
Okay, very good. Then I will just press on, knowing that the slides are advancing. Thank you. Great, so here we are. So the CSFP program, as noted here, is designed to support the health of elderly older folks, at least at the age of 60, by supplementing their nutrition needs with USDA foods. This program is also administered at the state level and works through public and nonprofit local agencies to ensure that folks have the services that they need. Ultimately, local programs work to determine eligibility, provide nutrition education, and ensure that foods are distributed to the populations in question. Funding for this program is limited. It does currently operate in 39 states, including the District of Columbia, in addition to 2 Indian reservations, but otherwise is available in a community near you. If you look at slide 19, the next slide, I have just here a quick image for what a sample CSFP senior food package might include. These commodity items are designed to meet the basic critical nutrition needs of senior participants. Moving on to slide 20, I talk just briefly about the Emergency Food Assistance Program. On this slide, you will see that the TFAP is a federal program that helps supplement particularly the needs of elderly Americans, providing them emergency foods. These nutritious, high-quality USDA foods are made available to eligible individuals. These include public and private nonprofits, households, and those who receive prepared meals, particularly older adults. This program is not means tested, meaning that income is not a determinant for participation. On this next slide, you have a little diagram that shows you a little bit about how this program works at the national, state, local levels, and how benefits ultimately flow to beneficiaries at the local level through emergency feeding organizations. So through the national program, funding is distributed to the states. There are different organizations along the continuum that can provide support ultimately to beneficiaries. These emergency feeding organizations, as noted here, food pantries, soup kitchens, and shelters, ultimately provide the benefits to the downstream participants. On that next slide, we'll talk a little bit about the Senior Farmers Market Nutrition Program. These are grants to U.S. territories, federally recognized Indian tribal organizations to provide fresh produce via coupons at farmers markets, roadside stands, and CSA, or community-supported agriculture programs. Those who benefit from this program are those who are at least 60 years of age and older and meet federal poverty guidelines. This particular program is administered through a federal and state partnership, as noted here. In my next slide, I just have a picture of the coupon in question so that you have a sense for how the beneficiary is able to receive this benefit and apply them to acquire food. It's important to note that while these programs are available, they are uniquely targeted to meet the needs of older adults. In slide 24, we can see here a continuum of need. This is to suggest that based on the ability of the senior to ambulate, move around their community, they can benefit from a series of programs. So ranging from the most mobile seniors to the least mobile, we can see how the different services do apply and meet their needs. So those seniors who are able to get around the community, access different resources, they can benefit from the SNAP, Senior Farmers Market Nutrition Program, and the supplemental food programs as noted. However, as folks are less able to move around their community, they can benefit from other types of programs, such as the congregate meal program and home delivered programs for seniors who are least mobile and homebound. Let's talk a little bit about these last two programs, the congregate meals and home delivered meal programs. On the next slide, we have an image that shows some more information about how these different food services and nutrition assistance programs interact. Again, providing you additional detail about eligibility, level of funding, the number of older adults that are served, the level of unmet need, and the jurisdictions in which these programs operate. This slide is small, I apologize, but it does give you a sense for how the programs are structured. So ranging from grocery or food meal assistance programs all the way to meal-based programs, you can see that these programs are designed to meet older adults at their point of need and provide a range of services that they would be able to offer. Next slide, please. So, for those seeking services to meet the needs of older adults in their community, they're invited to turn to the Aging Network. This is a partnership at the federal, state, and local levels to support the needs of all Americans residing in their communities of choice. Local agencies include what we call area agencies on aging, as well as a network of senior nutrition programs to provide a range of long-term services and supports to help older adults live independently, well-nourished in their communities of choice. So, nutrition services are among the most popular services that are offered in this continuum of long-term services and supports, and often serves as a gateway service into the Aging Network. That might be the very first service that an older person might confess to having a need for, reach out to engage in. So let's talk a little bit about the Aging Network so you have a better sense in the next slide for how these services are offered. Here's a bit about the structure in this diagram. You can see at the very top, the Aging Network is administered at the federal level by AOA, that is the Administration on Aging in the Department of Health and Human Services. Beneath this federal structure are 56 state units on aging, in addition to over 260 tribal organizations. These organizations ultimately support the needs of over 600 area agencies on aging that have regional jurisdiction to provide nutrition and aging services to the seniors in their localities. This results in over 20,000 service providers and 500 volunteers that work all across the country to support the aging needs of members of our communities, our families, our loved ones. What does this translate in? This means that through the federal government and this network of state, local, and volunteer actors, we're able to provide services and supports to 1 in 5 seniors across the country, translating into millions of meals, rides to and fro in the community, personal care services, assisting the needs of caregivers, in addition to providing hours of much-needed respite for those providing direct aging care. Let's have a look at the next slide to talk a little bit more about how some of these nutrition services play out in the community based in the aging network. So depending on a senior's ability to ambulate, get around the community, they can access congregate meals at a designated central location in the community or home-delivered meals, also known as Meals on Wheels. Some of the basic nutrition offerings in these services include meals that are hot, cold, frozen, shelf-stable, undeveloped, particularly to meet ethnic or cultural or special diet needs. Next slide, please. This is an important opportunity for folks in the community, regardless of their physical function, to access nutrition services they need. But it's also important to note that these services are provided in addition to an array of additional services that meet the needs of seniors. Many of these are noted here. In addition to nutrition services, many senior nutrition programs offer programs with regards to fall prevention, caregiver support, transportation, in-home safety, medication adherence, as well as chronic disease self-management programs. So we call this a more than a meal approach, meaning that while nutrition services are so important, we know that the other needs of the senior have to be met as well. Next slide, please. Folks who are interested in finding more resources can turn to the following sources. Next slide. If you're interested in identifying meals in your community, we invite you to visit the Meals on Wheels America Find a Meal feature. You can find this at mealsonwheelsamerica.org as the URL to visit, and by typing in your zip code or a city and state of interest, you're able to identify a suite of services and programs in your local area to support the nutrition needs of seniors that you serve. The next slide helps consumers who are interested in finding nutrition information. The National Resource Center is available at nutritionandaging.org to meet the needs for nutrition professionals and consumers alike. Just type in the area of interest into the website and receive curated listings of resources to meet your need. Next slide, please. So closing remarks will center on a call to action that, based on the nutrition needs highlighted here, the services that are available in your community, I hope that will culminate in your ability to serve seniors with an attention to nutrition needs. So the next slide, let's get into this a little bit more. There's such an opportunity for the integration of nutrition into healthcare services. We know that sound nutritional status is so important in supporting health and wellness, recovery from illness, and delaying or helping folks manage the onset of chronic illnesses. And so we know that there's growing interest and recognition in the area of nutrition and how folks at the clinical and community-based level can partner to address the issue of poor health outcomes and avoid and potentially avoidable readmissions. So we know that they're implementing more and more nutrition interventions between hospital and home, including home-delivered meals as one of those opportunities. Next slide, please. And this is so important because we know that there is a blind side, if you will, on the healthcare arena. We know that based on a recent Robert Wood Johnson survey of physicians, we know that many noted an inability to competently address their patients' social needs and know clearly that unmet social needs directly lead to health. Over 80% of the surveyed physicians indicated this selection. Next slide, please. When asked in this survey what physicians could do to help, 1 out of 7 wished they were able to write prescriptions for the kinds of services they would need. Many of those prescriptions are listed here, of which nutritious food is high on the list, in addition to an array of other services. Next slide, please. It is a growing awareness on the part of healthcare practitioners, in addition to folks on the community side, that we are learning and talking more and more about social determinants of health. Food, as noted here, is a key determinant and one that there's more and more resources available to address. And I know that Heather will be talking about this in her presentation. Next slide, please. So this much we know. While medical care is important, we know that it alone is insufficient because there are other socioeconomic conditions that present risk factors that routinely address our health. But ultimately, providing services that are targeted to a client's point of need, understanding their full ability to access resources, for instance, physical function as being a challenge for older adults, targeting them with client-centered services that address and meet them at their point of need are really important. And there are programs available to ensure a successful result. Next slide, please. So where do we go? Ultimately, we are embracing of the healthcare reforms that have occurred, opening up opportunities and payment models for greater integration of clinical and community-based care. We know that creative partnerships are key. In addition, an approach to thinking out of the box, as well as a degree of risk tolerance, meaning jumping into the unknown, moving into areas that we know are important and imperative to provide the needs for older folks. Next slide, please. So I wanted to take the opportunity to add a little bit to the diagram on social determinants of health and update this to add more emphasis on the nutrition area. In addition to addressing social determinants in the food pillar, as noted on this slide, hunger and access to healthy options, nutrition education is also so key. We know that food insecurity is particularly important, and in discussing and understanding how one can influence positively local food environment is also key. Food security, as listed here, is the subject of the next presenter, and so I look forward to hearing more information, but invite you to consider social determinants in this updated framework, where there is opportunity not only to address hunger and food access, but really looking at the issue of food insecurity as well. Next slide, please. We know that is this important? We know that malnutrition, or a consequence of not having access to the right foods, is expensive, as recent literature tells us that over $51 billion can be attributed to malnutrition-related costs for the healthcare system. Last slide, please. So there are lots of programs in the community to support the health and well-being of older adults. We know that with greater cooperation, communication, and collaboration, we're able to work across all settings of care to meet their needs. Thank you so much. Heather, I'll turn things over to you.
Well, Uche, do you want to take a few minutes to do questions?
Absolutely.
Why don't you take questions while I set up my presentation? So I think if people have questions, I don't know if the lines can be unmuted or if they can write questions in on the chat box. I'm not sure. Perhaps Sarah can provide some guidance.
Great. I'm looking at the chat box now in case there are questions.
Thank you so much, Uche. This is Christine. As we mentioned, if you have any questions, you can either unmute yourself or type it into the chat box. Dr. Akobundu is with us until 1 o'clock, and so if you have questions related to anything that she presented, please feel free to ask now. And then we will move on for Dr. Hartline-Grafton's presentation.
Thank you so much for the opportunity to present. Thank you, Heather, for advancing the slides for me. I really appreciate it and look forward to hearing your presentation.
Great. Well, I will get started with my presentation. It is wonderful to be with you all today. I realize that some of you may not be very familiar with the Food Research and Action Center, or FRAC, so I wanted to begin by sharing a little bit of background on the organization. So FRAC is the leading national nonprofit organization working to end poverty-related hunger and undernutrition in the U.S. Some of our key activities are listed here on the screen. I won't read them all to you, but in general, we lead efforts to identify and communicate the connections between poverty, hunger, and obesity. We conduct research on hunger, and we actively seek stronger federal, state, and local public policies that will reduce hunger. And we also monitor the implementation of laws and serve as a watchdog on programs. And we also provide quite a lot of coordination, training, and technical assistance and support on nutrition and anti-poverty issues across the nation. And we also conduct public information campaigns to help promote changes in policies and attitudes. And in recent years, we have been actively engaged in efforts around addressing food insecurity in healthcare settings, which leads me to today's presentation. So today I will cover the impact of hunger on older adults and how to address food insecurity in health settings for this population. More specifically, I will provide a brief overview of food insecurity among older adults and the connections between food insecurity and health. And then I will talk about an online course that FRAC developed with the AARP Foundation focused on the how-tos of screening and intervening on food insecurity. And I will conclude with some additional screen and intervene resources that might be of interest to you. So to begin, an analysis from FRAC shows that about 1 in 10 households with an older adult age 60 or over is food insecure, meaning that these households face uncertain or limited access to adequate food. And this is a national number. But here on this slide, we can see that there are state food insecurity rates that are available, and they're available on the website listed at the bottom of the slide. So as an example here, because I currently live in Texas, the food insecurity rate among Texas households with seniors is 11.3%. So this is a very useful research for those of you working at the local or state level to get some data down to more to your local level. And certain older adults are at higher risk for food insecurity than others. Research shows that food insecurity rates tend to be higher among older adults who are low income, less educated, Black, Hispanic, separated or divorced, or never married. Rates are also higher among older adults living in the South, who are unemployed, who live with a disability, who live alone or with children, and also among those considered younger older adults, I should say. And then research also shows that food insecurity is associated with some of the most costly and serious health problems in the U.S. This slide provides some examples of the diseases and conditions that have been linked with food insecurity in older adults. The examples include diabetes and hypertension, depression, limitations in activities of daily living, poor dietary intake, and so on. And because of limited resources, those who are food insecure often engage in coping mechanisms that are harmful for health. So for instance, those who are food insecure may be foregoing the foods they need for a special medical diet, or they may be purchasing less nutritious food due to cost. They also may be making trade-offs between food and other basic necessities, and this in turn can lead to poor health outcomes. So for example, there's a growing body of evidence on the connections between housing instability and poor health. Research also shows that adults often restrict their food intake to protect the children and grandchildren in their household from hunger, which can also lead to harmful implications on the adults. And then many struggling with food insecurity also are forced to choose food over medication or postpone preventative or needed medical care due to financial hardship. And just to reinforce these points, one national study found that 1 in 5 older adults experiences at least one of the following: food insecurity, skipped meals, difficulty paying bills, medication cutbacks, and dissatisfaction with finances. Again, this is 1 in 5 experience at least one of these. And the practices and behaviors I've listed here on the left not only exacerbate disease and compromise health, but they also increase expensive physician encounters, ER visits, hospitalizations, as well as increased expenditures for prescription medications. And so it probably comes as a little surprise that household food insecurity is a strong predictor of higher healthcare utilization and higher healthcare costs. And in 2014, the health-related costs of hunger and food insecurity in the U.S. were estimated to be $160 billion. And in another study, researchers estimated that those experiencing food insecurity have an extra about $1,800 in healthcare expenditures each year compared to their food-secure counterparts. And these extra healthcare expenditures are particularly high among food insecure adults with heart disease, diabetes, and hypertension, as you can see here on the screen. So for more information on the consequences of food insecurity, I encourage you to check out FRAC's Hunger and Health series. The first paper in the series is on the screen here. It reviews the latest research on the harmful impacts of poverty, food insecurity, and poor nutrition on the health and well-being of children, adults, and older adults. And the paper is available on the FRAC website. So hopefully in just the past few minutes, I've demonstrated that food insecurity impacts millions of older adults in the nation, and that food insecurity has costly and serious health consequences for the individuals and the healthcare system. But what do we do, and what actions are necessary to address food insecurity? And today I will focus on what can be done to address food insecurity in healthcare settings. We at FRAC worked with our partners at Feeding America and Children's Health Watch to identify 4 key actions to effectively address food insecurity in healthcare settings, as well as community-based settings working with vulnerable populations. This slide lists those 4 key actions. So first, it is important that we educate the healthcare community that food insecurity is a social determinant of health that may be contributing to existing health challenges or that can put people at risk for future health issues. And then next, it's critical that the healthcare community, as well as other community-based agencies, identify patients or clients at risk of food insecurity. And these groups are well positioned to do this. They just may need some help in getting started or with implementation. And third, once patients or clients are identified as at risk for food insecurity, they need to be connected to the federal nutrition programs like SNAP, or which is also known as food stamps. They need to be connected to emergency food providers, congregate and home delivered meal programs, and so forth. And this is to address both the short-term and the long-term needs of patients. And finally, we want to engage as many people as possible, including healthcare providers, in advocacy and educational efforts to end food insecurity and poverty in the nation. And it is especially important to get the healthcare community involved in these efforts because their stories are quite often so powerful because they can speak firsthand to the challenges faced by at-risk patients in meeting the challenges at-risk patients face in meeting both their food needs and their health needs. So the healthcare community is well positioned to identify food insecurity and to take actions to help address food insecurity, but many don't have the knowledge or resources they need to be effective or comfortable or successful in addressing food insecurity. And we at FRAC hope to close these gaps in a number of ways. And one of those ways is through an online training course on addressing food insecurity among older adults. And I will share more about the course in a few minutes, but one of our first activities in developing the course was conducting an online survey to gain insight and feedback from healthcare providers. And I wanted to share some of the findings with you today just so you have a better sense of what healthcare providers know or don't know about food insecurity. So we distributed an online survey through email in October of 2015 to a variety of healthcare providers through personal contact lists, professional listservs, and organizational distribution lists. And for the purposes of this survey, the term healthcare provider was used broadly and included physicians, nurses, social workers, dietitians, community health workers, administrators, and so on. and providers were eligible for the survey if they were currently in practice and serving adults 50 years of age and older. And we had 127 individuals in our final sample, including 49 medical doctors from a wide range of settings and professions, including, in a wide range of health professions, specialties, geographic areas, and medical settings. As you can see here on this slide, I've included a few examples. And one thing I do want to stress, though, is that this was a very small, convenient sample of healthcare providers, so just keep that in mind when I highlight a few findings from the survey. So respondents were asked to indicate their level of knowledge on a number of items related to food insecurity, and I'm going to walk you through this slide because there is a lot of information here. So on this chart, the blue color indicates no knowledge, orange indicates being somewhat knowledgeable, and green indicates being very knowledgeable. And for example, looking at the top of the chart, 25% of those surveyed reported no knowledge of the prevalence of food insecurity among older adults. And we saw similar low or limited levels of knowledge for food insecurity risk factors and consequences. Just over half reported having no knowledge of how to screen for food insecurity, and about 47% reported having no knowledge of how to intervene when a patient screened positive for food insecurity. And on the bottom, you see that about 1/3 had no knowledge of SNAP enrollment and participation. And again, SNAP is the Supplemental Nutrition Assistance Program, formerly known as food stamps. So overall, the findings indicated that there was limited knowledge about food insecurity in this sample of healthcare providers. Next, all respondents were asked about the barriers that they face in routinely screening for or addressing food insecurity among older adults. The top 5 barriers are listed here. Almost half report that time constraints are a barrier. About 42% report that not knowing enough about the issue is a barrier to screening and intervening. About 28% report that community-based interventions that address food insecurity are unavailable to them. And resources being unavailable and not knowing how to ask about food insecurity round out the top 5 barriers. And these findings are very consistent with our conversations with healthcare providers and medical organizations, especially time constraints and lack of knowledge. So the barriers listed here are very important issues we try to address in our various tools and resources for healthcare providers. Survey respondents were also asked whether their practice screens older adults for food insecurity. About 1/3 of respondents report that all or some patients are screened for food insecurity. That is what's shown in the orange and blue color. About 20, and that was pretty encouraging, but 25% report that patients are not screened, and that's the gray slice of the pie. And I will be honest, what really surprised me was that 39% did not know if patients were screened for food insecurity. So this slide shows that at least among this sample, there is work to be done to increase screening and awareness of screening. And overall, through our survey, we saw a number of knowledge gaps and opportunities for us to consider while developing the online course and other resources. So now I will turn from the survey results that helped inform the course to the course itself. This slide shows the title and opening screen for the course, as well as the course website, seniorhealthandhunger.org. Over 1,200 people have taken the course since it launched last year, and this includes physicians, nurses, dietitians, social workers, students, interns, social service agency staff, and the list goes on. So for this course, older adults refer to adults 50 years of age and older. However, a lot of the information and strategies are relevant across the lifespan. And this free online course takes about an hour to complete, and it targets healthcare providers and community-based agencies working with older adults. The course has been approved for continuing education credits, and the course also includes a number of downloadable resources, including posters and charts that can be used in clinical and community settings. And I'll share a few examples of those later on in the presentation. And then finally, throughout the course, there are interactive knowledge checks and activities which help learners better understand and retain the information. So there are 5 key objectives of the course. After completing the course, learners will be able to define food insecurity, to identify risk factors for food insecurity among this population. They'll be able to identify negative health outcomes that food insecure patients may face, They will feel comfortable in using the Hunger Vital Signs screening tool, and then they will be able to connect individuals to SNAP, other nutrition programs, as well as community partners. So I'm going to share some screenshots of the course so you have a better idea of how it works. So this is one of the screens from our opening model, and it lists the 5 main sections of the course. And I covered a lot of the information already that we have in modules 1 and 2 in terms of prevalence, risk factors, and consequences of food insecurity. But I thought I'd spend a little bit more time in modules 3 and 4, which focus on the specifics of screening and intervening. So this screen from Module 3 provides information on the Hunger Vital Sign, which is a tool that may be relatively new to some of you. The Hunger Vital Sign is a 2-question screening tool that can be used to screen for food insecurity. And the questions and responses are listed on your screen to the right in the blue box. So within the past 12 months, we worried whether our food would run out before we got money to buy more. And then within the past 12 months, the food we bought just didn't last and we didn't have money to get more. And a patient screens positive for food insecurity if they respond often true or sometimes true to either or both of the statements. On the left side of the screen describes the many benefits of using the Hunger Vital Sign. It's easy to use in clinical and community settings. It's been validated in a variety of populations. It can be administered verbally or in writing. It's available in multiple languages. And then Module 3 moves on to go into much more detail on the how-tos of screening for food insecurity. And some of you working with older adults may be using a different tool for screening for food insecurity. There are several out there, but this is what we have been recommending because it has been validated in a variety of populations. And so in Module 4, we focus on the various resources available and strategies to use when somebody screens positive for food insecurity. The key programs here are very similar to what you just heard Uche share in her presentation. So the key programs include SNAP and congregate meals, home-delivered meals, TFAP, and so forth. But given the lack of knowledge about SNAP among healthcare providers, we spend a substantial amount of time in Module 4 focused on SNAP. And also, SNAP is the only food assistance program available to all eligible older adults in every part of the country, which makes it very unique compared to other food and nutrition programs. So on this screen, learners can learn more about SNAP benefits, SNAP eligibility, and SNAP effectiveness. But I want to take a step back from the course for a moment to talk more about SNAP and seniors. And SNAP is the first line of the nation's public policy defense against hunger and undernutrition. It's administered by the U.S. Department of Agriculture, and the monthly benefits provided by SNAP enhance the food purchasing power of eligible low-income families. And the benefits can be used only for food and are delivered through electronic benefit transfer cards, which are used like debit cards at authorized food retailers. And SNAP benefit allotments are calculated based on household income and size. And according to the latest figures, SNAP serves more than 39 people each month and is by far and away the largest of the federal nutrition programs. In fiscal year 2017, SNAP served an average of about 5 million households with seniors each month, and this represents about 24% of all SNAP households. Senior SNAP recipients who live alone receive an average SNAP benefit of about $105 a month. SNAP reaches by far and away more seniors than any of the other federal nutrition programs available to seniors, but the program could serve and reach millions more eligible seniors. Only an estimated 45% of eligible seniors participate, and this compares to 88% of non-elderly adults. So why this low participation in SNAP among seniors? And there are a variety of reasons. I've listed a few here, including stigma, misinformation about the program, lack of information on how to apply, barriers related to mobility, and the list goes on. And so one of the key strategies in our work to address senior hunger is to close this participation gap and connect more eligible seniors to SNAP. And FRAC has interactive maps and accompanying tables that show the share of all households with seniors that participate in SNAP nationally in each state and across all the nation's counties. And so, again, using Texas as an example here because it's the state I live in right now, 11% of households with seniors participated in SNAP compared to 11.2% for the nation. So again, going to the link on the page at the top of the slide provides some really useful data for those of you working in the local and state level. We also recently released state-based fact sheets on how SNAP matters for seniors, and the Texas example is listed here. And one thing I want to point out, and I'm highlighting it in a yellow box, you can see how many seniors are missing out on SNAP in your state. So in Texas, only about 36% of eligible older adults are participating in the program. And these fact sheets are available on the FRAC website, and I encourage you to check them out and use them in your work. Because so many seniors are not participating in SNAP, they are missing out on the many health benefits of the program. There's a strong research base for SNAP's effectiveness in improving food insecurity and the health of children, adults, and seniors. And among older adults, SNAP participation is associated with reduced hospitalization, less costly hospital stays, reduced nursing home admissions and costs. And also, older adults participating in SNAP are less likely to be depressed and less likely to engage in cost-related medication non-adherence. And I just want to remind you all of what I was sharing earlier about how many seniors are not being able to afford medication or having those trade-offs between food and medicine. But SNAP can help address that issue to some extent. And one study published last year linked SNAP enrollment with lower healthcare costs among low-income adults, and this was for adults 18 plus. But the study estimated savings of about $1,400 per person per year through participation in SNAP. And in a different analysis, our friends at the Benefits Data Trust found that every senior enrolled in SNAP saves over $2,100 in healthcare costs each year, and they also estimated that we could save billions of dollars in healthcare costs if more seniors were enrolled in SNAP. So for more information on SNAP, I again encourage you to check out FRAC's Hunger and Health series. I mentioned the first paper in the series earlier in the presentation, and the second paper in the series focuses on SNAP's role in improving health. And the third focuses on the child nutrition programs and health, which may be of interest to some of you. But as a whole, all three papers really provide the evidence needed to make the case that hunger is a health issue and that the federal nutrition programs are effective health interventions and supports. So I encourage you to include those papers in your toolbox. So now I want to get back to the course. We took a little detour so I could provide some more information on SNAP, but here we are again in Module 4. The module has given some background information on SNAP to help providers and other learners better understand the program, but we also developed a number of patient-provider scenarios to better equip the healthcare community to address patient concerns and barriers related to SNAP. So here in the scenario that's on your screen, we see that the patient Richard is hesitant to apply for SNAP because he doesn't feel comfortable accepting charity or welfare. And a potential response for a healthcare provider is offered, including how SNAP is not a handout, but it's a program that can help the patient purchase the food they need to be healthy and independent. And we have several additional scenarios in this module, which again are designed to better equip healthcare providers in addressing potential concerns patients or clients may have about SNAP enrollment. Module 4 also offers specific strategies for connecting at-risk patients to resources. And I'm just going to provide a high-level overview of this for you now. But for the in-house model, patients are referred to on-site case managers, patient navigators, social workers, community health workers, trained volunteers, and so forth. And patients receive help in accessing programs, including possibly being screened for SNAP, or they may be referred to an on-site food pharmacy. For the external model approach, the patient consents to an external referral to a partner organization, such as an anti-hunger organization, and that partner organization meets with the person in person or by phone to connect them to resources. And then in the resource distribution model on the far right, a patient is given the contact information for a local community-based or government agency for assistance. And while this requires less effort for a healthcare provider, we have some anecdotal evidence that this approach is not as effective as the other approaches. The final module in the course, our fifth module, covers special considerations in working with older adults, and this includes considerations for older adults who may be raising their grandchildren and what that dynamic may mean for a food insecure household. And so this module also, or on the screen here, you also see a section of the course that talks about how to be sensitive when discussing food insecurity and how food insecurity is often invisible, so we should not count on appearances when when trying to determine if somebody is food insecure. We should use our validated screeners to determine if somebody is food insecure. And earlier in the presentation, I mentioned that there are downloadable resources available through the course, and here is one example. The poster focuses on not needing to choose between food and medicine, and this is something that could be posted in an exam room or a waiting room. Here's a poster specifically on SNAP that we hope can help reduce the stigma linked or associated with program participation. And all of our posters are free and available in English and Spanish. And I also wanted to point out our Federal Nutrition Programs and Emergency Food Referral Chart. This is available through the course as well as the FRAC website. This is a 4-page document, and I'm showing you page 1 here. And the general idea is that this document can serve as a resource on programs available to patients and clients. So the chart includes the name of the program, the population it serves, it provides a general description of the program as well as eligibility criteria. And because this is an interactive PDF that can be downloaded and edited, the document can be easily tailored to include information on resources in your local community. So that concludes my overview of the course, but before moving on to FRAC's other screen and intervene resources, I wanted to highlight a recent editorial in JAGS by members of the No Print Food Security Working Group. I was one of the authors on this editorial, and I'm really proud of it. The editorial came out late last year, and I think was published in print, I think it was in January or February. And the editorial targets healthcare providers working with older adults, which is really relevant given today's discussion. The editorial discusses the prevalence and health consequences of food insecurity among older adults, and then describes essential strategies for clinicians to address food insecurity in this population. And a lot of that information is, of course, addressed in the course that I was just discussing. But this provides a little bit more of a nice introduction into the topic because the editorial was only about 4 pages long. Early successes and resources are also included, such as the online course I reviewed. And we also provide specific policy recommendations. So, for example, we include multiple policy solutions to close the gap in older adult participation in SNAP. So the editorial, again, is a nice complement to what I just covered today, but really digs deeper into policy change than we were able to cover in our online course. So I encourage you to check out that editorial. And if you have difficulty accessing it, just reach out to me. My email will be at the end of the presentation. So in wrapping things up, I wanted to share some of the other resources and tools focused on healthcare settings that we at FRAC have developed. They're available on the link here. I'm just going to highlight a few things in the time we have left. So we partnered with the American Academy of Pediatrics to release a toolkit for pediatricians to address food insecurity among children. And the toolkit is intended to help pediatricians and their teams screen for food insecurity using the hunger vital sign. And then if someone screens positive for food insecurity risk, the toolkit provides information on how to connect families with food and nutrition resources in their community, including SNAP and WIC, school meals, and emergency food providers. And finally, the toolkit provides specific strategies for pediatricians to support and advocate for national and local policies that increase access to adequate food for all children and their families. And in terms of this last action, we developed 10 advocacy strategies for healthcare providers as part of the toolkit. Many of the strategies can be applied to the adult and senior patient populations as well, which is one reason I wanted to bring it up today. So many healthcare providers are actively engaged or thinking about screening for food insecurity, but perhaps the advocacy component hasn't been as much on their radar. And as I mentioned earlier, the healthcare community plays a really critical role in advocacy around food insecurity. So taking the first advocacy strategy listed here as an example, Healthcare providers can write an op-ed or a letter to the editor providing a personal account of the impact of hunger and poverty on their patients. Another action is for healthcare providers to meet, call, write, or email their congressional representatives to appeal directly to the members of Congress and offer expert information. And all of the strategies include a brief description of the advocacy action, plus at least one specific example. So while these 10 advocacy actions may be very geared towards children, again, they can be applied to adult and senior populations quite easily and seamlessly. The FRAC AAP toolkit also includes posters, infographics, and other tools for use in healthcare settings. Here, for example, is a free poster that can be posted in a waiting room or exam room. FRAC also co-convenes the Hunger Vital Sign National Community of Practice with our partners at Children's Health Watch. The Community of Practice works to facilitate conversations and collective action among a wide range of stakeholders who are interested in addressing food insecurity through a healthcare lens. And the group collects and conducts research on the connections between food insecurity and health. We promote the use of the Hunger Vital Sign to screen for food insecurity, and we champion effective interventions to address food insecurity both at the practice and policy level. The group includes healthcare professionals, researchers, advocates, nutrition service providers, policy experts, and so on. And we typically meet quarterly through conference calls. Our next call is scheduled for August 15th. And if you're interested in learning more about the group or joining the group, you can reach out to me through email or reach out to my colleague Rich at Children's Health Watch. And the Hunger Vital Sign Community of Practice released a document last year focused on coding for food insecurity in the medical record. And despite the interest and attention to food insecurity in healthcare settings, available healthcare terminology and codes to document food insecurity and related activities are underutilized and underdeveloped. We are working hard to remedy that. Excuse me. But this issue brief reviews existing and emerging opportunities to document food insecurity screening, assessment, intervention, and billing for each part of a patient visit. So this may be of something of interest to you on today's webinar. So I covered a lot of ground today, so just to do a quick recap, I hope you understand and see clearly that hunger is a health issue for older adults. I talked about how hunger contributes to poor health, poor disease management, higher healthcare use, and increased healthcare costs. And I also talked about the importance of SNAP for older adults. FRAC's online course is an important resource for addressing food insecurity among older adults in healthcare settings, and hopefully the other resources I described are helpful as well. And so I was thinking about the take-home message or what you should do after today's webinar, and based on my presentation, I would suggest the following next steps for those of you in attendance or who may be listening to the webinar's recording. So first, I encourage you to take the online course and to encourage others to take the course as well. You should also read the JAGS editorial. If you have trouble accessing it, again, just let me know. And then you should check out FRAC's Senior Hunger webpage to review all of the resources that we have that focus on senior hunger and poverty. And then check out FRAC's Screen and Intervene webpage to review all of our resources on addressing food insecurity and healthcare settings. And if you're on the FRAC website, I would also encourage you to consider signing up to receive the latest news updates and resources from FRAC on hunger, health, and federal food assistance. So that concludes my presentation for you today. My contact information is here if you would like to reach out to me after today's webinar. And in the time we have left, I am happy to answer any questions that you might have. So I'm going to pull down my presentation so that I can see the chat boxes a little bit better.
Thank you so much, Heather. And we do have it open for questions at this time. And I do see a comment in the chat box. And Heather, can you see the comment as well?
I see something about culturally customer service provided at the HSSA. I see that. Oh, I see. Okay, never mind. I am scrolling up and I see things a bit better. Okay. I like this. There you go. The lack of culture. I think I see a comment about being a barrier being the lack of culturally appropriate customer service And I think that's something we talk about quite a lot in our SNAP toolkits. We have some resources specifically on SNAP and older adults, and we talk about the importance of the cultural competency in that work. So that's a really excellent point. If there are any other questions, feel free to add them in the chat box. I don't see any other ones at this point.
No, that was the only one. If you have questions, you can also unmute as well. I don't know if you, for those who are on the webinar, just so you know that you are muted, and if you have questions, please unmute yourself. You can also type your question into the chat box as well. Additionally, if you have comments, like Eva had a comment about the lack of culturally appropriate customer service. If you have comments that you would also like to share, please chime in. So I wanted to say thank you, Heather, for providing all of the great resources at the end, particularly the JAGS article mentioning that, as well as the course. I think oftentimes people are unsure where to find information. So things like the course that you have, as well as the resources that you have on your site are very helpful. I do want to mention to everyone that we will also be coming out with a fact sheet on food insecurity among older adults once we get it approved through HRSA, and we will also post that on our site at the National Center for Equitable Care for Elders. So if you have, we have a few more minutes left. So if you have any questions, feel free to unmute yourself or type them into the chat box, and we will ask our guest speaker to respond. So Heather, this is Christine. I'll actually ask a question that I was curious about. We saw a lot of statistics on food insecurity, particularly among older adults, and I'm wondering if you find that you see more food insecurity within either urban or rural locations.
I believe we see pretty high rates in rural settings, and I believe the FRAC fact sheets that I mentioned, they address that to some extent. But one thing I want to say about the stats that I find very interesting is that you see these higher rates among younger older adults. So there's much higher rates of food insecurity among 50 to 59-year-olds, and we see that food insecurity tends to decrease with age somewhat due to the availability of age-specific safety net programs like Medicare and Social Security. So that's something I didn't really dig into in the presentation, but I think it often gets overlooked. And as a population, we don't often focus on that 50 to 59-year-old range, which is one reason our course focuses on older adults 50 plus.
Great, thank you so much. Any additional questions from our participants on the webinar? Questions or comments? Well, we wanted to thank Heather and Uche again for presenting on food insecurity among older adults. Looks like we do have a question, and yes, we will have the slides available. We will be posting a copy of the presentation on our website at the National Center for Equitable Care for Elders. We'll also post that in the BIPIC Primary Care Digest as well. So you can look out for the digest announcement of when it will be posted online. And so yes, you can access it there. Any additional comments or questions? Okay, well, thank you so much, Heather, and thank you, Uche, who's left us now. But thank you again for talking to us about food insecurity among older adults. For the participants, we will be sending out a post-link assessment that we would appreciate if you completed as well. And so thank you so much again, and I hope that everyone has a great day.